welcome to the deep dive. This is where we take your source material notes, articles, whatever you've got, and really drill down to pull out the most crucial, high-yield information. Today, we're zeroing in on a specific condition, Pemphigoid Gestationis. And this session is really designed for you, listener, to give you a sharp, focused revision based directly on the material provided.
Exactly. We're looking at Pemphigoid Gestationis, or PG. It's not common, but it has some really distinct features and, importantly, implications that arise because it happens during pregnancy. We'll unpack the key info together.
Okay, let's dive straight in then. Pemphigoid Gestationis, PG. First things first, what exactly is it? Can you give us that core definition?
Right. So the material defines it as an autoimmune bullous disease. Key things: autoimmune, blistering, and happens specifically in pregnancy. Underlying it all is this process where complement and sometimes immunoglobulin gets deposited in a very specific place, the lamina lucida, which is part of the skin's basement membrane zone.
Autoimmune, so the body is attacking itself, essentially.
Precisely. The immune system mistakenly targets part of the skin. And there's an interesting historical quirk mentioned in the sources. It used to be called herpes gestationis.
Herpes gestationis, that sounds confusing.
It really was. And the material stresses this despite that name. It has absolutely nothing to do with the herpes virus. Zero connection. It was named purely based on the appearance of the blisters. Kind of a morphological thing, not the cause.
Wow, okay. Good thing that name's gone, mostly. Though it's a lot of unnecessary worry, I imagine. So, autoimmune blisters in pregnancy. What makes someone susceptible? Any known triggers or risk factors?
Well, the information links PG sometimes with hydatidiform mole or even choriocarcinoma, so there's an association there to be aware of.
Okay, so specific pregnancy-related conditions, potentially? Anything else does having PG, indicate anything broader about a person's health?
Yes, and this is actually a really crucial point from the material, high yield for you to remember. It states quite clearly that patients who've had PG have a significantly higher risk of developing other autoimmune diseases later on in life.
Ah, right. That connects back to the autoimmune definition, doesn't it? It suggests maybe a general predisposition?
Exactly. It's like the PG episode might be the first sign of an underlying tendency towards autoimmunity.
That's a key takeaway, then. It's not just isolated to the pregnancy. What kind of other autoimmune conditions are we talking about? Does the source list examples?
It does. The specific examples given are Hashimoto's thyroiditis and pernicious anemia. And later on, when discussing prognosis, Graves' disease is also mentioned. So think thyroid issues and B12 absorption problems.
Hashimoto's pernicious anemia, Graves's. Okay, so PG acts almost like a warning sign for the future immune system behavior. Got it. Let's get into the how, then. What's actually happening pathologically? What's the mechanism causing the blisters?
Okay, pathophysiology. So patients develop these specific antibodies, mainly IgG1 class, and these antibodies target components within the skin's basement membrane. They bind there. That binding sets off an immune response, brings in complement, inflammation, and the end result is a separation between the epidermis and the dermis. That creates the space for fluid to collect, forming those subepidermal vesicles and blisters.
So the antibodies stick to the glue, holding skin layers together, trigger inflammation, and cause separation. Blisters form in the gap. That makes sense.
Yeah, that's a good way to think about it. The sources also note there's some antigenic overlap, meaning the target looks similar to the antibodies found in bullous pemphigoid, another autoimmune blistering condition.
Right. And do we know why these antibodies form in the first place during pregnancy? What's the initial trigger?
That's the million-dollar question, really. The exact trigger isn't fully known, but the material suggests a leading theory involves cross-reactivity, maybe between some placental tissue components and similar-looking components in the skin's basement membrane. The immune system gets confused, if you like.
Interesting. The immune system's complexity during pregnancy is just fascinating. Okay, so we know what it is, broadly how it happens, but how often do we actually see this? Is PG common?
No, definitely not common. Actually, it's quite rare. The figures quoted in the sources vary a bit, but put the incidence somewhere between 1 in 50,000 pregnancies, all the way up to maybe 1 in 2 million pregnancies in some populations.
Well, 1 in 50,000 is already pretty uncommon, but 1 in 2 million, that's incredibly rare. Compared to something like, say, PUPPP, this is way down the list in terms of frequency, right?
Absolutely. Way down. The incidence seems to be influenced by the prevalence of certain HLA types in a population. The material specifically mentions a higher incidence in Caucasians and links this to HLA-DR3 and HLA-DR4 haplotypes being more common in those affected.
So a genetic component contributing to its rarity and distribution. Given it is so rare, being able to spot it clinically becomes even more important. What does it actually look and feel like for the patient? Key clinical features.
Right, the clinical picture is vital. High-yield stuff here. Typically, it appears in the second or more commonly the third trimester.
Okay, late pregnancy.
Yes, often with a pretty sudden onset. And the absolute hallmark symptom, the thing patients complain about most intensely, is the itch, pruritus. It's described as extremely severe, debilitating even, not just a bit itchy.
Right, intense itch. Got it. What about the rash itself? What are we looking for?
It usually starts as these red urticarial papules and plaques, so raised red patches, a bit like hives or nettle rash, often starts around the umbilicus, the belly button area. Then these patches evolve, often quite quickly, into tense vesicles and bullae, proper blisters filled with fluid and quite firm or tense to the touch.
Okay, so it starts like hives, maybe around the belly button, then boom, tense blisters. Where does it typically spread? Is there a pattern?
Yes, the distribution is a really helpful clue. It typically begins on the abdomen and trunk, then spreads outwards to the limbs. But crucially, and this is a key point, the sources emphasize it characteristically spares certain areas: the face, the palms of the hands, and the soles of the feet.
That sparing is important. Face, palms, soles usually clear. What about inside the mouth? Mucosal areas.
Generally spared too. Mucosal involvement is uncommon, reported in less than 20% of cases according to the material. So you're mainly looking at the trunk and limbs, avoiding those specific sites.
Okay, that pattern is very distinctive. What about the timeline? Does it just keep getting worse until delivery?
It can fluctuate. Interestingly, the symptoms sometimes improve a bit in the last few years before delivery, but then there's often a flare-up quite soon after the baby is born, postpartum. The good news is it usually resolves completely on its own within weeks to months after childbirth.
But does it come back, like in future pregnancies?
Yes, recurrence is definitely a feature. The sources mention it can recur in subsequent pregnancies, quite commonly, in fact. And sometimes it can even be triggered later in life by things like starting oral contraceptives or even just with menstruation, which again suggests that hormonal link.
Right. So let's try a quick clinical snapshot then, based on what you said. Third trimester patient, sudden onset, incredibly icky rash that started as red patches near her navel and now has tense blisters spreading on her arms and legs. But her face, palms, and soles look fine. Pemphigoid Gestationis has to be high on the list, right?
Absolutely. That combination, the timing, the intense itch, the morphology, urticaria to tense blisters, and that classic distribution with sparing is very strongly suggestive of PG. Recognizing that pattern is key.
Definitely. But pregnancy rashes can be tricky. What other conditions should be on our differential diagnosis list? What else could look like this? Or cause severe itching or blisters in pregnancy?
Good point. The differential is important. The sources list several key ones. Obviously, other autoimmune blistering diseases like bullous pemphigoid itself or cicatricial pemphigoid. Then there are the more common pregnancy-specific dermatoses, especially pruritic urticarial papules and plaques of pregnancy, or PUPPP that's much more common and itchy, but usually lacks the big tense blisters of PG. Also need to consider things like linear IgA dermatosis, dermatitis herpetiformis, maybe erythema multiforme, papular dermatitis of pregnancy, and pruritic folliculitis of pregnancy. It's quite a list.
Yeah, some blistering, some just itchy. It really highlights why you need to confirm the diagnosis properly. So how do we do that? How do we nail down PG and rule out the others? What investigations are key?
Well, first off, the sources say routine blood tests, like a full blood count or basic chemistry, aren't really helpful for the diagnosis itself.
Okay, so standard bloods don't help much. What does?
It's really a combination. You need that characteristic clinical picture we just discussed. Then, a skin biopsy is essential. You take a small sample of skin, usually from the edge of a blister or an affected area.
And what does the biopsy show?
For histology, looking under the microscope, you'd see that characteristic subepidermal split or blister formation. But the really crucial tests are the immunofluorescence studies.
Right, immunofluorescence. There are two types mentioned, aren't there? DIF and IDF.
Exactly. Direct immunofluorescence, or DIF, is done on a fresh skin biopsy sample, usually taken from skin right next to a blister, perilesional skin. It directly looks for those immune deposits, the complement, specifically C3, and sometimes IgG stuck along the basement membrane zone in the skin itself.
Okay, so DIF finds the evidence at the scene of the crime, so to speak.
Yeah.
Finds the C3 stuck in the skin.
Precisely. Then there's indirect immunofluorescence, or IDIF. That's done on the patient's blood serum. It's looking for the circulating autoantibodies, the PG factor or IgG antibodies that are floating around in the blood, ready to attack the skin.
So IDF finds the weapon, the antibody in the bloodstream. Makes sense. DIF for deposits in skin, IDF for antibodies in blood.
That's the core of it. Finding that linear C3 deposit along the basement membrane on DIF is considered the gold standard diagnostic finding for PG. The sources also mention HLA typing can be supportive. Finding HLA-DR3 or DR4 increases suspicion, but it's not diagnostic on its own. Oh, and a small caution from the material. Sometimes the DIF pattern in PG can look similar to bullous pemphigoid, or another condition called epidermolysis bullosa acquisita. So you always interpret the lab results alongside the clinical picture. It's not just about the test result in isolation.
Right. Clinical picture plus histology showing the split, plus the crucial immunofluorescence results, especially DIF showing C3, confirm diagnosis. Okay, so we've confirmed it's PG. How do we treat it? What's the management approach?
The mainstay of treatment, and this is based on UK practice mentioned in the sources, is oral corticosteroids, usually prednisolone. That's the go-to for controlling the inflammation and, importantly, that awful itch.
Prednisolone, and that's used during pregnancy and postpartum if needed.
Yes, both during pregnancy and often continued or restarted postpartum if there's a flare. The typical starting dose range given is around 0.5 to 1 milligram per kilogram per day.
Okay, steroids are key. What about just managing the itch symptomatically?
Absolutely. Antihistamines are used pretty routinely alongside the steroids to help provide some relief from the severe pruritus. Emollients might help soothe the skin too.
And what if it's a really severe case or doesn't respond well to the steroids? Are there other options?
For those tougher cases, the material mentions things like plasmapheresis or immunoadsorption could be considered, but these are definitely second or third line treatments, much less common. One thing the sources really emphasize for management is the need for a team approach. Collaborative care involving the obstetrician, a dermatologist, and also a pediatrician is recommended.
Yeah, that makes total sense. You've got implications for the mom's skin, the pregnancy itself, and potentially the baby. Needs everyone on the same page.
Definitely. It's managing both mother and potential fetal outcomes.
Okay, so speaking of outcomes, what is the overall prognosis? We know it's usually self-limiting after birth, but are there any complications or long-term issues for the mother or the baby we need to be aware of?
Well, the most reassuring news first. The sources state there's no increased risk of maternal or infant mortality directly from PG, so it's not typically life-threatening in that sense.
That's good to know. But are there other impacts on the pregnancy or the baby's health?
Yes, there are. There's a documented higher rate of premature births, the sources mention around 20% risk of preterm labor, and also a higher chance of babies being born small for their gestational age, or SGA.
Okay, so increased risk of prematurity and growth restriction. Important for obstetric monitoring. Does the baby ever get the rash?
Sometimes, yes. In about 5 to 10% of babies born to mothers with PG, they might develop a mild transient blistering rash themselves.
Ah, why does that happen?
It's thought to be because the mother's IgG antibodies, the ones causing her rash, can cross the placenta and get into the baby's circulation. But because the baby isn't producing them, as the maternal antibodies get cleared from the baby's system over days to weeks, the rash just fades away on its own. No specific treatment usually needed for the baby's rash.
Okay, so transient rash in a small minority resolves spontaneously.
Mm-hmm.
Good. Now, circling back to the mother. What about her long-term health? We touched on this earlier.
Yes, and it bears repeating because it's a significant long-term consideration highlighted in the material. That increased lifetime risk of developing other autoimmune diseases, they'll list again: Hashimoto's thyroiditis, Graves' disease, pernicious anemia.
So having PG is a definite red flag for a future autoimmune follow-up for the mother. That's a really crucial counseling point, isn't it? If a patient has had PG, she needs to know about this increased future risk.
Absolutely. It's a key part of the long-term picture. So main complications: prematurity risk, 20%, SGA risk, potential transient baby rash, and that significant long-term maternal risk of other autoimmune conditions.
Okay. It really shows how PG, while rare, sits at this interesting intersection of dermatology, obstetrics, and immunology.
It really does. You see the interplay between the hormonal changes of pregnancy, the immune system's response, and how it manifests on the skin. It's quite fascinating, even if challenging for the patient.
Absolutely. Well, this has been a really focused deep dive into Pemphigoid Gestationis. We've covered its definition as an autoimmune blistering disease of pregnancy, the link to future autoimmunity, the classic clinical signs like intense itch and blistering sparing the face bone soles, the key diagnostic role of immunofluorescence, management mainly with steroids, and the important outcomes for both mother and baby. Hopefully this run-through has been a really useful, high-yield revision session for you.
For more free MSRA revision resources, you can visit freemsra.com, and for the full premium revision toolkit, head over to passthemsra.com.